Greetings, guys. We are talking about telehealth and the nuts and bolts. This is going to look more at the practical application versus clinical application. So it's a little bit more what goes on behind the scenes. Some topics that I have are safety, connections, space, and forces at play. And that is going to show you the different types of connotations each one of these terms has. So let's start off with safety. Job number one for any healthcare practitioner is to maintain safety for the patient, and there's no difference in the virtual environment. However, there may be some nuance to the virtual environment. So first and foremost, you have the intake paperwork or intake forms. You're still going to scan those for the potential of their complaints being something that's better seen by a different practitioner, and or you are going to use that as a way of screening that information to maybe refer them and treat if they have complaints that are consistent for physical therapy, but also something else going on that they have not been assessed yet by a different healthcare practitioner. So one of the other things that we tend to collect with our intake paperwork is also the address for the patient. Well, it's important to note that some people do not have high-speed internet, so they may go to a different location for their treatment. They may end up going to a Starbucks, they may end up going to a friend's house, whatever it is. So you're going to want to collect the address of where they are going for the treatment, not just their home address. This becomes important for a couple of different reasons. One is, in the case of an adverse event, you'll know where to send the emergency response team, but also from a safety of the patient's privacy, it becomes important. Remember that half the battle is making sure there's nobody behind you that's listening to the interaction, but you also need to make sure that there's nobody behind the patient that should not be listening to that interaction between you and the patient as well. So this is going to help you guide them and say, Starbucks is probably not the best place for us to have our discussion, and brainstorm with other available places for this interaction to occur. Now, you'll see also the available assistance. So let's say that the person is able to do this interaction with you in their home. Is there somebody else in the home that may be able to provide them assistance through your evaluation? An example would be you might need this patient to do a 30-second sit-to-stand test. They may or may not have the ability to get the chair, the area in a good position for that test. So might there be a younger person or a more able person inside of the house that can move the chair over to the wall, at which point you can go through and have that seat be more stable for the test in and of itself. You also want to know the mental aptitude of that person in case an emergency does happen. Does that person have the ability to go outside and flag down the emergency response team? Do they have baseline CPR level training? What is their ability to assist you in a serious adverse event? Now remember, with the emergency response, if it's the person by themselves, you've already identified where they're going to be located, but now you may need to get additional information on how to access the home. And that's where that previously mentioned source or person that's going to be their next of kin, their brother, their wife, whatever it is, that's where they come into play. Because you may, while you're still on the screen, have to pick up your phone, call that point, that emergency contact number and say, hey, it looks like something's going on. I need to send an emergency response to the patient's address. Do you know if there's any special things that emergency response needs to know? Such as dogs, such as you can only enter from the west side of the building, things along that line. That way you can help out with guiding that emergency response team in the most efficacious way. And the next one is more related to differential diagnosis. I touched on it a little bit already, but remember that your job through your interaction with the patient is to prove that they don't need physical therapy. Prove that their complaints are associated with something that's better seen by a higher level more medically complex professional, such as a doctor or a physician, So if you fail to prove that they don't need physical therapy, that's good, because now they do need physical therapy and you know that you've done your due diligence to prove the safety of that patient to see you. Now we move into connections, and the obvious one that people think of with telehealth is the internet connections, but remember that this is still a human interaction. And with there being no direct face-to-face contact, you might lose some of that human aspect. So do recall that you really want to, at least for the first 3 minutes or so, make sure that you're making eye contact, you're really responsive with your gestures so that the patient can see it. If I do a subtle head nod, they're not going to be able to see that quite as well through the screen, so maybe be a little bit more embellish, maybe is a good term. Embellish your movements a little bit more. This is very similar to some of the behaviors you'll see with a television reporter where they're really moving around to convey the feeling that they have. Now, that should be a process that continues the entire time. It should never get to the point where the person's just talking and you're just sitting there typing away at your note. This is something that you should be able to still jot some shorthand, come back, and pay attention to. So establish that human connection. The other one that is very important for telehealth is the internet connection, making sure that they know they need to be close to the router, making sure that they need to have all of their different apps on their device that they are not using for this interaction turned off for a couple reasons. The first primary reason is any other app that's open is going to be using some of the resources within their computer. It's going to slow down how well your telehealth app or your telehealth draw off of the computer processor works. So shut everything off that they don't need. The next thing is making sure that anybody else who's on the network doesn't steal away from their bandwidth. So make sure that they know that their kids should not be streaming movies on that same network that you're trying to stream this health interaction. So shut down the other devices as best they can. Same thing goes, however, for you. You need to make sure you do the same processes. Turn off extra apps. Turn off or ask anybody else who's using your Wi-Fi to not stream high load, heavy demand apps or movies or anything like that while you're trying to provide this treatment. The next thing is, again, more the human side, and that's maintaining connections. With the person leaving the clinic, oftentimes there's a nice kind of closure that happens as they're leaving, a nice handshake, whatever it is. You don't get to have that in telehealth. So I would make sure that you try to get in the habit of sending a personalized email response, sending a personalized video response, and using the portal if your EMR or EHR allows you to have a portal with the patient to maintain privacy. If you don't have that, you can still use email and whatnot. Just make sure it's a little bit more bland. That way you're not putting any of their personal health information at risk and risking you to some of the repercussions of violating health privacy laws. Space. This is the next one. Space is, again, multi-contextual, or it has a lot of connotations to it. So the first one is room to respond. Just like in a regular interaction, you're going to have this drive that says, I need to fill in blank time. Well, remember that patients need some time to think about your question. So I'd advise you to put it somewhere between 5 and 10 seconds after a question in order to give them time to reflect on that question and move forward. So give them space to respond to your questions. Don't just try to gun through it. You also need to have room to move. This becomes important if you need that person to do squats, if you need that person to lie down on the floor and do range of motion, active range of motion on the ground. They need to be able to move. So I usually recommend they have at least 10 feet behind them that they can do that in, if not further. But they also need to have the ability to tilt the device up or down. So bringing it up or bringing it down in a way that allows the transition from one position to another position while on camera to happen very cleanly. They're not struggling with their phone because it keeps falling down every time they try to point it at them on the ground. So making sure that you've given them advice on how to do that. For me, I made an email that goes over that process with them. So that's something that can be done. Now, the next one is room for error. Remember, none of us is an expert at telehealth. It's too new of a modality. It's too underutilized by patients at this stage. So there's a lot of room for error. And because there's room for error, there's room for you to laugh at yourself. There's room for you to giggle. I've definitely gotten to the point where I've had a patient try to point the camera at the ground. It falls 4 times. We're laughing. That's that human connection. So don't get upset if it starts to get a little fuzzy. It just means that you got to work around it. The other thing is there's room to play. And this one I really like because it allows you to experiment a little bit. Be transparent in telling the patient that you're experimenting with certain aspects of this care. But remember, the technology should always serve a purpose. You shouldn't just be filling the technology without a purpose. So play, but play with the purpose of that play in mind. The next one is a little bit more clinical application, but remember that there's a lot of forces at play, not just the joint forces, but also critical thinking. You're going to have to brainstorm some things in order to get the information that you need, and that might lead to some differences in the applications, so some critical applications for your diagnostic processes. An example of critical thinking of your knowledge base and the application to it might be a hip test. So let's say that I needed to do a FIDEER test or a flexion adduction internal rotation test for the hip looking for impingement. I can't put my hands on there, but I know that I need to have forces drawing that knee or the hip, into a flexed, adducted, internally rotated position. I put my foot onto a chair, and now from there I try to lean over that leg, allowing that to come across midline. I can even ask the person to pull it across their body, and that can recreate their symptoms. So it is not the true definition of the test, but it's close enough to allow me to get some useful information. I can look at the range of motion that occurs there. There's several different ways of looking at it, which goes back to the whole idea of having room to play. All right, guys, so that is the cumulative sum of the technical aspects of telehealth. Please do let me know if you have any questions. If not, please consider utilizing this modality in your practice because I do think it's going to be quite beneficial. Bye.